quick background on why this emotional regulation plan is a part of the violence prevention protocol. And that is because there's a lot of research that shows fostering emotional regulation in kids and taking the time to understand who kids are can really help decrease violent events. And the emotional regulation plan also seeks to do collaboration with patients in terms of how they can regulate their emotion in a way that's authentic to who they are. The individualized emotional regulation plan is an opportunity to have a conversation with the patient and their families about how we as MBMI staff members help kids stay safe when they are engaging in unsafe behavior that either is going to harm themselves, others, or is very threatening in the milieu. It's an unavoidable part about working on an inpatient psychiatric unit, and unsafe behaviors are often a reason kids get admitted to an inpatient unit. And the emotional regulation plan opens up the conversation of how do we want to problem solve. The first section of the emotional regulation plan is checking some boxes. And this is a list of important considerations when de-escalating a patient or considering a patient's violence risk. Some of these things you will know through your admission assessment and attaining the patient's history, but some of these things you can ask the patient. A big one would be, are they triggered by male or female staff? They may deny that they have a trauma history, but for whatever reason just feel unsafe or uncomfortable around a certain gender. Another thing you can ask a patient is if they have any particular triggers. And patients who are new to the mental health care system may not be familiar with that word. And so a way to rephrase the word triggers is you can say, hey, is there anything in particular that makes you anxious or makes you feel on edge or uneasy? As far as triggers go, that's something you can add on to throughout their stay, because helping patients identify their triggers and writing those down is a useful tool for them and you as a staff member. All the things in the important considerations sections are things that are also very important to pass on and report, which is why they're included in this document. This document is another thing you can use during your shift change, to get yourself familiarized with the patient. So this list was developed with adolescent staff members and are just some top things you would want to know about a patient you haven't met before. The value of this important considerations section is also to give you a quick snapshot of how to best approach the patient when they are escalated. There's a lot of things that goes into de-escalating a patient, and it works best when you know the individual. As the adolescent unit is transitioning to a 14-bed unit, each staff member's capacity to understand and learn who the person is going to be diminished. These are all things that I would consider and factor in to how I de-escalate a patient. For example, if they're triggered by males, I would make sure that there's a female staff present, and is the female staff who is having the direct de-escalation conversation with the individual. Cognitive delays and developmental delays really make me cue in to how I'm communicating and make me consider how much is this person understanding what I am saying. In general, when people are emotionally escalated, they are not processing information well. And it is crucial, regardless of the person's cognitive processing and developmental level, to communicate clearly, set firm, consistent boundaries, and have patience. Unpredictable and impulsive behavior, I think it's the Wild West. All bets are off. If I know a patient has a history of unpredictable or impulsive behavior, I'm much quicker to call security and much quicker to take additional measures to make sure the rest of the unit stays safe. Another big thing that we have found over time is that some patients escalate when they see security staff. It is so critical to use security as a way to ensure unit safety and patient and staff safety. But it is also really helpful to have conversations with security as they come in and change shifts about who are acute safety risks and what they can do. One useful technique for working with a patient who already has a history of violence in the healthcare setting and is kind of emotionally amping up at all is to be very frank about how we deal with violence and just unsafe behavior on MBMI. Let them know that violence and unsafe behavior is not tolerated, and we are here to help them problem solve in a healthy, productive way. Patients who have a known significant amount of overwhelming anxiety are people who you should keep your eye on, because anxiety can be so overwhelming it leads to unsafe behavior that requires intensive intervention. And so these patients may be cooperative with treatment and engaging and just sweet, wonderful people, but when their anxiety gets too high, their behavior can become very unsafe. History of trauma and unsafe behaviors. This is a section you can just write in some facts. And if a patient has an overwhelming history of trauma and unsafe behaviors, keep it to the things that are most important to communicate with other people and would be useful if you didn't know the patient and were attempting to de-escalate them. For example, things can cause trauma for a child that you may not think about. For example, like having their dog die. It's sometimes fun to de-escalate a patient by having conversations about pets or animals. But if they've recently had a dog die and you bring that up, that may further escalate the situation. For unsafe behaviors, once again, you're trying to, in a snapshot, get a better sense of how to predict and prevent the patient from having unsafe behaviors while they're on the unit. So if they've had a history of eloping before and they're starting to escalate, you can keep your eye out and make sure that your badge is tucked in and that they are unable to access doors. Another big one with suicide attempts in the inpatient unit to keep your eye out for is ligature risks and kids who attempt to commit suicidal acts while they're asleep, using their sheets or pillows while they're in bed. So those are big things that come to mind for this section that you would want to include. Self-harm is another thing to document in this section and is especially pertinent in the inpatient setting, as the inpatient psychiatric unit is a stressful environment. Kids often have such a limited amount of coping skills, and self-harm is an effective way for them to reduce their stress. Writing down self-harm and then maybe how they self-harmed can be effective. For example, it's common for kids to self-harm on the unit with pencils or erasers or paper clips. Those objects and knowing what we can remove and make sure the patient doesn't have access to can be helpful, because simple self-harm attempts can lead to further escalated episodes. Strengths, interests, and motivating factors. This is once again a section where you can just write some things in. This section can include a variety of things, like the person's pet or the person's summer plans, the name of the patient's favorite friend that they may enjoy talking about, their favorite activities to do on the unit, their ideal careers, or favorite extracurricular activities or TV shows. Get creative here. It's all about engaging the child with the things they care about in their life. Currently, in the adolescent admission process, we are not asking kids what their strengths are, what interests them, and what motivates them. So this is something new we are collecting about patients that we haven't before, and it can really help build therapeutic rapport. Completing this section is an opportunity to have dialogue with the patient about who they are besides their mental illness and psychiatric admission situation. You can ask them, what are you interested in? What do you like to do with your free time? What do you want to do with your life? These questions are also pertinent to fostering resilience in children. When you ask a child, what do you think your strengths are, or what do you value about yourself? You're really helping them identify their innate capacity to build resilience. Knowledge about a child's strengths, interests, and motivations helps the therapeutic relationship and helps them engage in the therapeutic process, but it also helps us redirect and de-escalate a patient when they're engaging in unsafe behaviors. We can help remind them of their goals. We can help them remember why they should do the hard work of choosing healthy behaviors and emotional regulation. This question is about fostering the therapeutic relationship with the child. And the therapeutic relationships that kids can have with adult psychiatric staff members are huge to their experience on the unit and can be quite powerful in helping a child choose safe behaviors over unsafe behaviors. This list is some options kids have to engage in emotional regulation and deal with challenging feelings like anger or sadness or anxiety while they're on the unit. It's a basic place to start, and you can go through with the kids and ask them what sounds good to them. This list of ideas is to kind of further elaborate on the conversation with the patient and how we can preemptively help them deal with their emotions. When going through this list with children, it's important to emphasize that not all of these options may be available to them during their emotional crisis and in moments of emotional escalation. For example, when a kid becomes very anxious during group, there may not be the individual staff member there to have one-on-one time or take them out for a fresh air break. And once again, just because the kid is emotionally escalated and anxious, it doesn't mean it's appropriate for them to necessarily call an approved trusted adult if the context is inappropriate. It's worth reinforcing with kids that we can't always get what we want when we want it. And we have to keep improving our capacity to use many coping skills and keep improving how we can cope with the situation at hand. And so if one coping skill isn't available, it's a skill to be able to use another coping skill, even if it isn't your first choice. This last section, Other Considerations for Non-Core Staff, is an opportunity to write down anything that you think would be useful to know for someone who is unfamiliar with the child or is not consistently working on the unit. Often kids will be persistent with staff members who are new about trying to contact an adult or a friend. Normal adolescent staff are very good at setting that boundary, but when the new staff member comes on, they can get tricked. Another thing can be if a patient has difficulty with a certain time of day and tends to get consistently emotionally escalated, for example, at bedtime or in the afternoon or at shift change. As an adolescent staff member, you are in a role as a detective, trying to understand who this child is and why they are the way they are, and how can we help them. It's also worth sharing your detective work. So any clues, tips, or tricks that are valuable and make working with the patient more effective are also worth putting down in this section. Once you have completed the emotional regulation plan, it should be placed in the green binder that will live at the nurse's station. And the binder says on the cover, Emotional Regulation Plans. You can look at these emotional regulation plans as you need to familiarize yourself with the patients when you're new on shift. Additionally, you can review and update the emotional regulation plans if you find out new information or if a patient does have a violent event. You can go back and contribute to their triggers and what helped them emotionally de-escalate. And this will help make the emotional regulation plans a resource. Something that makes working on an inpatient psychiatric unit special, compared to other units in the hospital, is the depth of the therapeutic relationship with patients. But when there are up to 14 patients on the unit, this capacity is diminished. We can teamwork getting to know and provide individualized care to our patients by reviewing and updating the emotional regulation plans throughout our patients' stays.
Whoa. Now I feel chill.
This video is to bring you some education about what the research on adolescent inpatient psychiatric violence has to say in terms of staff member behavior. Decreasing violence through implementing interventions on an inpatient psychiatric unit require considering how. And that is to say, if patients have an amygdala monster, and there's a lot of patients with amygdala monsters, it's very possible for us as staff members to create our own amygdala monsters. One of the most important things we can do for patients is be present. And when we can control nothing else, the one thing we can still offer another person is our presence. And it's worth considering, what is our presence? Do we have our raging amygdala monster there with us? Or are we able to really be there, focused in the moment with the other person? And this is an aspect of performing effective violence intervention. Now, this is not just some hippie psychobabble. It's real. Within my research on inpatient adolescent violence, I found a very interesting study. This guy. And what it did is it took inpatient staff, had them go through a mindfulness course, and then every shift, staff members had 15 minutes to meditate. Now, not all staff members utilize that 15 minutes, but what they are able to show is that from before the mindfulness course to afterwards, there was a decrease in the amount of violence that occurred on the unit. And it was statistically significant to the point in which it was able to identify that the intervention of mindfulness and meditation for staff members was effective in decreasing violence. Our capacity to experience peace, contentment, acceptance of the current situation can affect our patients for the best. And it's evidence-based that our emotional regulation practices can influence our patients. Now, this gets pretty complicated when you look at the research about how inpatient adolescent violence affects staff members. For example, one study found that up to 40% of the staff members on a unit had some sort of PTSD symptoms related to events that had occurred on the unit. The research on how violent events affect inpatient psychiatric staff shows a variety of things. Beyond PTSD symptoms, there's the physical injuries, there is a decrease in morale, motivation, and overall job satisfaction, and there's correlations between increased amount of sick days and increased staff turnover. Consider how you may choose to practice regular self-care in terms of things that will help you feel calm, present, at peace, and remember that you are loved and that the world is a good place. It's worth asking yourself how a violent event has affected you or how it may affect you, because our ability to heal ourselves increases our capacity to heal our patients.